Welcome to Key into Quality, where we explore the foundations of a thriving quality culture in healthcare. I'm Dr. Tim Morgenthaler, a professor of medicine and vice chair of quality at Mayo Clinic. Today, we're going to discuss safety, but not our usual conversation about safety, where we're trying to prevent falls or errors in care delivery or infections. Those kinds of safety issues are related to work preventing mistakes. But instead, today, we're going to talk about safety from violence at our healthcare workplaces. Co-hosting with me today is Sherry Nemec. Sherry?
Hi, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. And every time I hear from our guests today about how much of a problem this is, I'm still kind of in a state of shock because I don't think most people realize what an issue this is in healthcare.
Sherry, just earlier this week, my son invited my wife and I over to have dinner with him and his girlfriend. And as we were catching up with each other's lives, his girlfriend mentioned that, she has an interview for a new job in a residential treatment center, helping patients navigate through their recovery from mental illness. And we were, on the one hand, thrilled to hear about her ambition and realized that this would be just perfect for her, given her heart and her skills.
Mhm.
But my wife's immediate question for her, and honestly, my first unspoken thought was, are you going to be safe? I think our concern springs from knowing that violence in healthcare is a critical and growing issue that threatens the safety and well-being of providers, but also of patients. I know that a recent report from the American Hospital Association actually said it's been increasing by 47% over the past 5 years. So this is a big problem, and this escalation, we can think about a lot of things that it might be attributed to, but when we're facing staff shortages, this can lead to longer wait times, which increases frustration, which increases you can
Right.
just see this snowballing. So, when I think about our Mayo Clinic values of respect, integrity, compassion, healing, teamwork, innovation, excellence, stewardship, we're really trying to lean in there. Today, we're really fortunate to have Mayo Clinic physician colleagues with us. They have been champions, really, at seeking ways to make our work environment safer from violence so that we can be compassionate and provide the teamwork needed to create that healing environment that's so much needed by our patients. So I'd like to welcome Dr. Casey Clements and Dr. Serena McGuire. Casey, welcome. Maybe you can just tell us a little bit about yourself, about how you found your way to Mayo Clinic and what you've been doing lately.
Sure. So I'm Casey Clements. I'm an associate professor of emergency medicine. I've been at Mayo Clinic in Rochester for 15 years. I trained here and then joined faculty. I actually joined faculty as an infection researcher. I have a PhD in microbiology and immunology, and I never thought that I would be working on violent patients and visitors. It's actually a lesson for some folks if you're starting out in academic medicine. If you do something and people like it, you probably will end up doing more of that thing. So be careful what you say yes to. But no, I'm
Right.
just kidding. I gave a talk back in 2011 about how to sedate agitated patients effectively because I just saw that need in the practice where we were working. And a couple of years later, they asked me to build a practice pathway for that. And a couple of years later, they said, do you want to lead behavioral health for the emergency department? And then we've built a mental health crisis center and a hospital unit for violent patients. And it goes to show if you work really, really hard, you can get your name on a policy for when patients should go smoke outside of the hospital because it's related to violence.
Wow. And also joining us today is Dr. McGuire. Dr. McGuire, tell us a little bit about yourself and how you got here, and what you're doing now.
Yeah, so I'm also in the Department of Emergency Medicine as an assistant professor, and I do work with Emergency Medical Services or EMS. I'm a medical director for our ambulance agency. I have been in Rochester, Minnesota for 5 years at the Mayo Clinic. I trained here as well, and I have an interesting background. I was a military police officer before medical school, and I naively thought that I was leaving behind prior experiences related to dealing with violent individuals when I entered healthcare. And that's not been the case. I've been victimized by violence in the healthcare setting. And I connected with Casey pretty early during my training. And we've been working on this shared passion together since 2019, 2020. And it started out with research and quality improvement, and it's leading more into translation into the clinical setting, trying to improve experiences for our staff and our patients as well.
Well, thank you to both for sharing a little bit with us and about your background and sort of how you've come into this conversation with us. And just to start to lay some groundwork, when we talk about patient and visitor violence, what does that include? Why it's important? What can you share with us there?
What is violence is actually a really challenging question. And I think if you asked a lot of people in the hospitals, in the clinics, what is violence, they immediately go to physical violence.
Mhm.
Someone is swinging or kicking or punching. Where we've realized over several years that those behaviors don't usually exist in isolation. In fact, lots of behaviors are on a spectrum. We've called it complex behavior. I'm not sure that's the perfect term either, but it appreciates the fact that sometimes there's microaggressions and bias requests, such as I only want a Christian doctor to see me. And those can progress to things like threats, verbal abuse, harassment. And the physical violence is only the tip of the iceberg. That is appreciated by some of our accrediting organizations. The Joint Commission has a very expansive definition of violence now to include those various things. Now, how much violence is going on is another question that I heard you imply. And we really don't know what we don't know. The literature would say that only 19% of even physically violent events are ever reported. So the numbers that you're seeing, Dr. Morgenthaler, when you talked about this increase of 47%, as a quality improvement person, that is actually good news to me because it's very counterintuitive. But if people are starting to report it more, it means that we're starting to measure it more, and so we can improve it.
I can really believe that because, some years ago when I was the patient safety officer is really when we started talking about this. And we realized at that time that a lot of the culture, at least at our health center, and I think other places, was many people kind of felt like accepting a certain amount of that was part of their job. And so they had a real reluctance to report. When in fact, I mean, some of the activities that were taking place were things that if it had happened outside the hospital, you would have called the police for. So getting people to kind of be more aware and more willing to come forth and to report was and has been, and I suppose still is somewhat difficult. I don't know what your findings are within our system about the reporting.
Yeah, so we actually implemented a checkbox in the ambulance agency service, EMR, or the pre-hospital electronic medical record, over a year ago. And we sought a quality improvement project where if we bring the reporting process to the point of documentation, would we see improvement? Trying to take out that barrier of the complex, time-intensive burden processes on staff. And what we found is that we captured an increase of 36-fold violent incidents, violent patient encounters in
Wow.
the pre-hospital setting. Only around 3% of them were reported through official reporting processes. So,
Wow.
like Casey Clemens said, you don't know what you don't know. And just because you might not have a capturing of violent events at your own healthcare system, it doesn't mean it's not happening.
Yeah. I think a lot of people, both inside healthcare, like I was just describing, and outside of healthcare, maybe unfamiliar with what goes on, have some assumptions about patient violence. What would you say are some surprising but maybe incorrect assumptions about patient violence?
That's a great question. Well, first, I think Dr. McGuire, tell us a little bit about your work that you've done looking at the disciplines affected, because I think nursing has been out in front of this for a long time. And we know that nurses are disproportionately affected by violence. They're at the bedside more than anybody else. But we started to look a little deeper into this and found some surprising things.
Yeah, we surveyed multidisciplines across our healthcare system right around the time of the COVID-19 pandemic. And like Casey said, it's mostly clinicians and nursing staff that have really been the brunt of attention for this important topic. And we found that all disciplines are experiencing violence, including respiratory therapists, ECG technicians, radiology technicians, phlebotomists, even housekeeping. And I can go on and on with all the different disciplines. So there's no discipline that's spared when it comes to workplace violence.
And as for why it's an issue in healthcare, I don't really know an answer to that. Certainly, there are some assumptions that OSHA has made about what are things that put you at risk for workplace violence, and they include things like working at odd hours of the day, working in emotionally charged situations, and the healthcare sort of fits the bill for all of those risk factors. But there does seem to be something qualitatively different that the way people behave in a healthcare setting than they would in the grocery store, for example. And the data around that is pretty scary. Now, I said we don't know what we don't know early on because the all violent events are not reported. But if we focus on physically violent events that result in non-fatal injury, that is a relatively reliable lagging indicator because people are missing work. People are taken away from their profession for a period of time. And I can tell you that 74% of all non-fatal injuries from workplace violence occur within healthcare.
Wow.
It's incredible.
Yeah. And I've read some statistics that actually, if you compare the risk of that in healthcare, it's not actually terribly favorable with regard to law enforcement or some other things where you would expect maybe people are almost voluntarily putting themselves in front of violent people, whereas that's certainly not on our minds, or really historically hasn't been on our minds when we come to work in a hospital.
I've been treated worse, I think, as a healthcare clinician than I was as a military police officer, to be completely honest.
Wow. Wow. I'm kind of going back a little bit to the assumptions thing. Let me throw some things out at you and get your comments, because I've heard this from nurses and physicians who, have been involved in scary circumstances. True or false? Most patients who perform violent acts are clinically mentally ill.
False.
Mental illness, and how do you define mental illness? I'm sure there's psychiatrists and psychologists that would have a different answer. But when I think about treatable axis 1 disorders, they're not generally associated with violence outside of substance use disorders. It immediately springs into our mind when someone acts in a way that's beyond the pale and is extremely violent, that we kind of knee jerk to that person must be mentally ill, because why else would they have behaved that way? I mean, we hear that rhetoric when mass shootings happen, for example. It's the first thing on everyone's mind. It's kind of a red herring, and it's not fair to folks that do have mental illness to stigmatize them that way. So it's not really a problem with mental illness in and of itself. It's multifactorial.
So let me throw out a related factoid. We can put it in quotes. Most violent patient-related injuries occur in the psychiatric wards.
False.
Tell us more about that.
Well, again, and I'll put a caveat on this. There's different reporting cultures. And so there are certainly violent things that happen within psychiatric hospitals, and psychiatric staff sometimes are more hesitant to report. I don't have hard and fast data around that, but I do follow our security reports daily, and I can tell you that they still do happen in psychiatric hospitals, but is by no means the most common or most dangerous place. There aren't actually any places that are immune to this, I think, is a better way to look at it. Dr. McGuire's done a ton of work looking at both pre-hospital care and within the emergency department to get a sense of this. But I also work in the inpatient unit on this, and I can tell you that floor medicine is very much affected. I can tell you the ICUs are very much affected. There's really nowhere that's not affected.
I would emphasize what Casey said. I'm looking at longitudinal violence right now from the pre-hospital to the ED to the inpatient setting, and it's occurring in every setting. I would agree. There's no one setting that's immune. And it is a substance use intoxication issue that we're finding with our data. And I find a lot of our clinicians are inappropriately terming that a psychotic issue or a mental health crisis when it's actually truly intoxication or symptoms of withdrawal from a substance that I think is getting kind of confounded.
The other side of that coin is that confused patients definitely contribute to violence, more so on the inpatient side than within the emergency department side. But certainly patients with delirium, patients with dementia, patients who are confused for any variety of reasons, the hospital's a scary place and they can absolutely become violent. I think the mistake is to think that that's any different. And I say that kind of tongue in cheek, but nurses don't tend to think of a confused person swinging at them in the same light as they think of someone who's intoxicated swinging at them. Certainly your response to those things should and would be different, but we tend not to report the confused person who's swinging. We tend not to come up with safety plans for people who are confused when they're doing violence. And that's a disservice to downstream staff because we really need to coordinate around all of those kinds of violence.
So, what kinds of actions have you undertaken or promoted to obviously create more awareness about what constitutes violence in healthcare, but how have you positively impacted getting people to report more?
I think Dr. McGuire's intervention is really fantastic, and she's gotten an innovation award to try to do that a little bit more broadly. Do you want to talk about your work?
Yeah, as I mentioned, we've increased the capturing of violent incidents by bringing the reporting tool to point of documentation, embedding it within the electronic medical record. And I really think the future of how we increase capturing of events and support staff is through increasing automation and trying to pull out variables from the electronic medical record to reduce administrative burden on our staff. And so I think one of the biggest things we can do is to really reduce administrative burden of our staff following a violent event and to really help support them after a violent event rather than making them kind of sit through three different reporting systems with occupational safety, with security, and even departmental leadership, really reducing the burden on our staff and supporting them from the time that a violent event occurs.
Yeah,
Mhm.
I'm so glad you're bringing up that point because, of course, we've been talking about the occurrence and the prevalence and the frequency and the risk factors. But, maybe you could just tell us a few words about what effects does this have on medical staff?
Yeah, so Casey and I actually asked this question in our Midwest health system survey, and we found that being a victim of violence affects the ability of over 1 in 5 of our multidisciplinary staff in performing their job. Nearly half indicated that violence has changed the way they interact with or perceive patients.
Mm.
Over 1 in 5 experience symptoms of post-traumatic stress as a result of an incident of violence, and nearly 1 in 5 have considered leaving their position due to an incident. And if you think about our current staffing crisis, I don't think that's sustainable.
This is critical. Yeah.
Absolutely.
The other thing I was going to ask that's along those lines, you got me really curious now, so now you're in trouble. So you're increasing the reporting. So yes, that makes us know better where to go look. It's the old, where do you look for the keys? Well, where the light is, you're going to actually find more. But what are we doing with that? So let's say we have it reported early on in their, in the ED or maybe even pre-ED. What happens then? Because I reported that. What happens to that? And let's say what affects that patient's care from reporting.
Yeah,
We'll have time to get into the other stuff later, but how does that change the trajectory of that patient's hospitalization?
it's a great question. So there's a number of different things that we do with information when it's reported. And the first thing that we need to do is we need to feed back to staff what we did based on what they said, because we have to be reliable in our response when somebody says that something has happened and they need help. And so we bring help to them through operational teams that are present at many of our sites across the enterprise. So there's a hospital safety pillar in Rochester. Certainly security is key partner and is involved. There is a violence mitigation team in Arizona and another one building in Florida. So there are resources that can be brought to bear on how do we plan around this person's encounter of care. We do utilize something called a behavioral safety plan at Mayo, where we can talk about what are the things that set off this patient or visitor related to behaviors? What are things that help mitigate that? What are things that help prevent that? What are rewards that we can offer to help keep people treating us with respect? How do we set expectations with those folks? That BSP also flags the chart that this person has had a behavioral event that downstream staff need to know about to coordinate care. And we're careful about how we administer those. There certainly is literature that some interventions like that could be prone to bias. And so we always have to have a mind towards equity as we're doing some of these things. Certainly, the same applies to if things go completely off the rails related to restraints and medication. The goal is not to get to there. So that's what happens in real time. Now, what happens with that specific event after the fact is also a big question, and it hasn't always been a reliable response. And we realized a number of years ago that folks, when it was appropriate and they were calling police to press charges for an assault, for example, a lot of times police would kind of shake it off and say, well, this is a hospital. They're probably sick. They're probably mentally ill, as we talked about. And there were assumptions from the law enforcement side.
Mm.
At the same time, even if charges were pressed, The county attorney, whose job it is to help bring those charges through the court system, didn't always have all the information that they needed in order to capture the emotional or physical effect of that violence on the employee. And so, one thing that we've done is we've built a community collaborative, certainly here in Rochester, where we sit down once a quarter with everyone from public safety in our community. So this is internal to Mayo. It's the jail, it's the sheriff's office, it's the police department, it's the county and city attorney, it's the caseworkers for adult and family services and child and family services. It's all of the folks that we kind of exist within a safety net for our community. And part of that is coordinating care around violence when it happens. Certainly, there's a lot of other benefits to that collaboration, but we were able to regenerate how reports were taken so the county attorney could have the information that they needed. We actually were able to put together a really unique collaboration with our police department where we have hospital resource officers, similar to a school resource officer, that are trained and they understand healthcare, they understand the situations of patients in the hospital, and they can help our staff work through policing issues. They don't do security. They're not security guards. They're really to do policing within our large hospital system. And so those sort of coordination things really make it so when someone reports, we can do something with it.
That's great to hear how we're Mayo Clinic in serving patients in our communities can't own and fix all of this, right? We have to include people from our communities and make this be a team effort to try to address. If, let's say, I'm a hospital leader, haven't really been able to wrap my arms around this workplace violence issue in my hospital, what are some things that I might be able to do to start addressing the concern, support staff? What tools and resources might I look for first?
As Casey mentioned, it's not just an issue isolated to the healthcare environment. It seems to be spilling over from the community and something that's kind of increasing in frequency in public overall. And so I think engaging with the community and with local agencies is really important. It's a solution's not only going to come from the healthcare environment, but it's going to come from the community environment. Education of staff about what constitutes violence, that we're trying to break down that barrier of this is a long-standing cultural belief or misconception that violence is just part of our job, because it's not. That's kind of one of the first things to help overcome this misconception and get staff recognizing when violence occurs, even if it's non-physical violence like harassment or verbal threats. And then simplifying reporting tools to start capturing the extent of the violence that's occurring, and improving resources to staff so that they feel supported after a violent event occurs.
I think you also need to build and resource a team to be able to manage this. A lot of times when people hear violence, they immediately think security. And security does a wonderful job. We need them. We need them there in the moment, and they can do a lot of things to help in these spaces. They can help with boots on the ground manpower when needed. It can help with alarms. They can help with cameras. They can do a lot, but they can't do everything. And one of the things that we found early on when we really centered a lot of our responses around security was that they don't understand that the nurse who just got swung at is going to have to walk back into the room of the person that assaulted them in 4 hours to get another set of vital signs. So this necessarily involves engagement of the practice. And so, similar to other models of leadership at Mayo Clinic, where we have triad models of leadership with an administrator, a nurse leader, and a physician leader, we kind of have built quadrad leadership models for violence with security, a physician champion who's very passionate, nurse leaders who are all passionate, I can tell you, and operational administrative support. When we started our violence journey in 2014, I remember the first meeting we ever had. They said, anybody in the hospital who's interested in working on workplace violence, come to this little conference room. And it was on the first floor of a Mary Bry building here in Rochester, Minnesota. And every single nurse manager in the hospital showed up.
Wow.
It was every unit. There was like no one who wasn't there. And we realized that we maybe need to be a little bit more directed with our approach.
So,
But that's amazing to even think about 10 years ago
yeah,
already, right? They were seeing this and needing to have some kind of response to the issue.
we could talk about this for a lot because your knowledge is very deep and wide. But let me just ask quickly, what's on the horizon for the work of this? What's up next in your work?
I alluded to it earlier. It's automation to reduce staff administrative burden, violence prediction tools, using artificial intelligence, and really improving cross-system collaboration and communication amongst the longitudinal care continuum, because the violent events aren't isolated to one department or one care setting. It's really happening across all settings.
And I think that continuing to integrate practice with security resources, to have a warm, welcoming, and healing environment, but also one that is safe. One of the things that we've started doing is passive weapons detection at several of our facilities to try to remove knives and guns from the healthcare setting. Certainly, we're talking mostly about events that are not involving weapons that are happening to us in healthcare, but it becomes a completely different problem when that person becomes irate if they have a firearm at hand. And so screening for those at point of entry and trying to prevent those from coming into our healthcare spaces, we believe can be really effective at preventing that very infrequent but very high profile event from happening. So continuing to leverage new technology, including video analytics, sound detection for when people are getting angry in our hallways and spaces, and sort of advanced passive weapons detection and elimination from the spaces, I think are also on the horizon as key improvements.
This kind of blows my mind. I hope we can engage in a more conversation with both of you. This has been fascinating, but we do have to bring our podcast to a close, and we're really glad that our listeners could join us. I just want to take a moment to thank both Dr. Clemens and Dr. McGuire for your passion and your intellect and your effort and your energy that you bring into this on behalf of myself as somebody who works in the system and all of my colleagues and all of our patients. Thank you so much. And on behalf of the listeners for sharing your knowledge and your passion with us all. We hope that our listeners feel this has been insightful and valuable. And again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you'd leave us a review on Apple Podcasts, a rating on Spotify, feedback wherever it is that you listen. And you can also follow us on your favorite podcast platform. Please let others in your organization know about the podcast so the information and learnings can be spread. Until next time, goodbye.